All right, everybody, welcome back to this podcast, Psychiatry Unboxed, with me, Sulman Aziz Mirza. I am a triple board certified psychiatrist who does podcasting on the side so that I can hopefully retire from my medical life and do something else. I have somebody, one of my favorite peoples, on the show today. So I'm going to have Dr. Katrina Furey. I'll let her introduce herself, and then we'll kind of like bio background, all that fun stuff, and then we'll get into what we're talking about.
Okay, cool. Well, thanks for having me. I am I guess, board certified adult psychiatrist. I trained at Yale, and I mostly focus on women's mental health and reproductive psychiatry. I spend most of my time these days in private practice called Sound Psychiatry in Guilford, Connecticut, and where I see patients clinically. And then I also help staff our state's Access Mental Health for Moms hotline, where providers in Connecticut can call for direct peer consultation with a reproductive psychiatrist like me and to help connect their patients to treatment. And the way we know each other is I also have a podcast called Analyze Scripts, where you've joined us, I think, 3 times now. I think you're like at the top of the list of our repeat guests for some really fun episodes analyzing the depiction of mental health in TV and film, like The Iron Claw, which I still haven't recovered from.
Yeah,
One
still
Flew
crying.
Over the Cuckoo's Nest, and Gremlins were the episodes you joined us for.
Yeah, so that was definitely like, I was like, we've been talking the movies and all that stuff, and I was like, you know what, we should actually like talk about some psychiatry stuff and what we actually do in real life. And
yeah,
because I think like what you do is super, 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 super important as well, and something that's super underrepresented, not recognized as much, and like a lot of misinformation is out there about this field. So I was like, let's do an episode on like postpartum stuff, reproductive psychiatry, all that fun stuff. So
I appreciate it. It's funny you say that, because when I was transitioning into private practice, it was right after I had my daughter, interestingly enough, my youngest child. I was like, I'm not going back to 40-hour plus work weeks. Like, I can't do it. Like, I want to be home with my daughter, blah, blah, blah. And I always knew I wanted to do private practice eventually. And then that really was the catalyst for me. And I remember telling one of my mentors, like, yeah, I'm going to open my private practice. I really want to focus on women's mental health and perinatal psychiatry. And she actually said, she's a mother too. She was like, oh, there's not really a market for that. I was like, what? Like, what? So even like within the field, I think it's kind of weird that people are like, oh, there's not a need. And I'm like, I think there's a huge need.
There's a huge need, right?
Turns out.
I was like, I'm sure you're pretty busy, right?
Yeah. Yeah, which is great. And I think like people are just going to continue having babies, so we should start helping them.
Yeah. I think babies are a thing, unless we watch like Children of Men, the Clive Owen thriller from way back in the day. Not way back in the day.
Oh my gosh, I think I did see that.
Where like, people stop having babies. But like until we get there, like this is something that's gonna be part of life, right?
Yeah, exactly.
Yeah. So I was like, we always start off with a surprise question.
Oh, good.
Okay. Just so like you're totally unprepared for this. But
okay.
Because we've done a lot of work on these Analyze Scripts, collaborating on this, right? What is your favorite movie?
That's the question?
Yeah, that's it.
That actually is a hard question. What is my favorite movie? I think I have to say I love Will Ferrell. Yeah. So I feel like it's a tie between Step Brothers and Elf.
Oh, okay.
Like I just really love those. Yeah, I don't know. I love Step Brothers. That's one of my favorites. We actually did an episode on it.
Yeah.
And I was really proud because on our Instagram at Analyze Scripts Podcast, and probably on our TikTok, also at Analyze Scripts Podcast, and maybe on my own personal Instagram at Dr. Katrina Furey. It took me forever because I'm not very good at social media, but I tried to make, the scene in the car where they're all singing. I think it's like the perfect depiction of a narcissistic family structure. And so one day I like filmed that scene on my computer, and I like made little like, this is the narcissistic dad and this is the scapegoat mom and here's the golden child. And I'm like really proud of it. So if you want to look at it, you can see it. But I just like love that movie. So I think Step Brothers probably.
Step Brothers is a good one. I think, any kind of comedies, though, I don't know what it was, but like during that, there was like that 10-year stretch or something like that, right? Where these comedies that they were coming out
with Will Ferrell, like every year. It was so great.
Bangers. We had like Old School.
Yes.
There was like,
Anchorman.
Anchorman.
Kicking and Screaming.
Yeah. all this stuff was
The Blades
fantastic.
of Glory,
Yeah.
Talladega Night. Yeah, that was like the golden years. Those are
Peak.
probably the best 10 years of my life. Also, I think it coincided with like med school time, which was actually like a really fun time in my life.
Yeah. Good. Well,
What's
that's
your favorite movie?
my favorite movie is True Romance. The
Okay, I
old,
haven't seen him.
yeah, it's an old Tony Scott movie. It's the Tony Scott movie, 1994. It's the movie that Quentin Tarantino wrote that allowed
Okay,
him to become Quentin
Quentin Tarantino.
Tarantino. And it was Christian Slater, Patricia Arquette, and then that's like the main characters. And then you have this all-star supporting cast of Christopher
Mm,
Walken, James Gandolfini.
mm,
You have Brad Pitt in a role. You have Balky from Perfect Strangers is in a role. So like it's one of those movies that like Gary Oldman has this classic
mm,
scene in there. So it's a bunch of like people having these classic scenes.
mm-hmm.
And it's just one of those like, violent, funny comedy, not comedy, but like, action movies from like the 90s with like just dripping with like charisma and just awesomeness.
Nice.
So yeah,
Awesome.
yeah,
Nice. I'll have to check that one out.
yeah, it's a good one. So, all right, now that that's out of the way, let's talk about reproductive psychiatry. What
Yes,
is
really
what
serious.
is reproductive psychiatry?
Well, so it turns out
Hmm.
that, all these hormonal transitions that women go through affect a lot of women. Like who knew, right?
Hmm.
I'm kind of being sarcastic. Well, I'm being really
Hmm.
sarcastic here because as I'm sure the
Yeah.
medical field's understanding of women's health, let alone women's mental health, like far lags behind men.
Well, it's pretty
Um,
repugnant. Yeah.
yeah. And so what I always tell my patients is it's like, we're slowly climbing out of the dark cave into the light. We're starting to understand it better and there's still a lot of room to go, but it turns out these hormonal fluctuations women go through actually do affect their mental health.
Yeah.
I'd say for most women. And so the field of reproductive psychiatry really focuses on treating various mental health conditions that arise at these time points. So around menarche, when you get your first period, when you get your period every month, in the case of premenstrual dysphoric
Hmm.
disorder, perinatal mental health conditions, women are at the highest risk of experiencing a mental health episode during and around the time they're having babies, and then during the menopause transition as well. So all of these time points, which basically is a woman's entire life,
Yeah.
it turns out it affects us.
It's one of those things that like I work, primarily my job is with teens, kiddos, and adolescents. And I think there was some statistic when I really started to be like, oh, PMDD is a real thing,
Oh,
right?
yeah.
When I started to really start to incorporate it into my interview and my
Mhm.
formulations and all that stuff, I think the numbers are like, 30% of people who menstruate are going to have to deal with PMDD symptoms. And it's like, oh,
Mhm.
that's a
That's a
big,
lot.
that's a lot of people.
Yeah, and even the ones who don't have clinical
Yeah.
PMDD, most of the other 2/3 will have PMS,
Yeah.
and women are just expected to function
Yeah.
totally normally, right?
And it's those things that like I hate saying it sometimes, like when I'm doing, the clinical work is like I was like, I hate to be that guy. But I was like, during that time of the month, like do things change for you? And it's
Well,
like,
I'm glad you ask.
yeah. I was like, first of all, I'm asking. And I was like, please don't think that I'm like being sexist, but I was like, you know what? There's research and data which
Yeah,
shows that there is the differences.
and in my experience, it's so validating to hear that.
Yeah.
Like, when I talk to people about that, they're like, "Oh, I'm not just a raging bitch." It's like, turns out no.
No,
Turns out no, it's not you.
there's something to it. And I
Right,
think,
yeah.
and I can't remember, I was like, there was some study that came out that I was kind of like, think about, can't remember the exact details. It was somewhere recently, but it was like, interestingly, like when people were trans individuals, when they were transitioning, right? So they were kind of looking to see what symptoms would kind of show up, right?
Mhm.
And when individuals were transitioning from female to male, their anxiety, depression symptoms went down.
That's really interesting.
And male to female, with the
They went up.
hormones, they went up.
That's
And
really interesting. I would love to learn more about that.
yeah, I'll find that article and send it on over. But
Yeah.
I was like, it was something that like really kind of stuck out. I was like, oh, maybe there really is something to this hormone thing.
Right. Yeah, for sure.
There's
And
something
that's
going
where
on
I
there.
think, like, I've always been a science nerd.
Mhm.
And, I think it's just so cool how this is the field I really ended up in, because
Mhm.
I started medical school thinking I wanted to go into neurology.
Yeah.
And then I really loved my OBGYN rotation, and it really like flipped me on my head, because I was like, oh my
Yeah.
God, do I want to do this? And then my psychiatry was my very last rotation of third year. And I was like, oh, this is what I want to do. But it's so cool now in the field where I get to use all of those. They've all like
Yeah.
coalesced into this field. I didn't even know this was a thing, like repro psych. There's not really like a fellowship yet that's,
No.
accredited. And you don't always get that exposure in residency. So it's just really cool. And I think the science behind it is really fascinating, and it's really
Yeah.
exciting that they're making discoveries, and we're seeing, the FDA just approved the first oral medication for
Mhm.
postpartum depression, and it works totally differently than
Yep.
SSRIs. And this is like so cool. And I'm really hopeful that over the course of my career, we see a lot of growth.
Yeah.
It's just really cool, the neurobiology behind it all.
I was like, there's a lot of things from there. First, let's kind of talk about you kind of mentioned it a little bit before, but like the sexism in medicine.
Oh,
And then just like, I know we're kind of opening a can of worms a little bit, but I was like the sexism in medicine, and then just how that influences, again, careers, right? So
oh
in
my
regards
God.
to, or like pursuits even. So like,
Mm-hmm.
we have people telling you like, why do you want to go into reproductive psychiatry? It's, there is
There's
no
not a need for
fellowship.
that.
There's no need for it. Like, so what was that like then for you in regards to being like,
Oh
this is what I want to
gosh.
do, and the journey that come along with it, finding mentors and etc.
Oh my gosh. I mean, I think the sexism it's one of those things where I think like you probably experienced this in your own way,
Mhm.
where it's like part of your lived experience that you don't even realize is sexism till you get to a certain point, or
Yeah.
you don't even realize is racism or classism or ableism, whatever the ism
Yeah.
is. I think until you get to a certain point, you reflect and you're like, huh, that's weird, right?
Yeah.
I mean, I would say, like, I vividly remember in my OBGYN rotation, we were in a surgery, a gynecological surgery. The whole team, except the attending, were females.
Yeah.
And the whole time, the OBGYN talked ad nauseum about how women should be home. They don't need to be at work. And literally, the whole team is female, right? And
Yeah.
you're just like, huh, that's interesting. And I think a lot of that, like, I think I also faced it, and so like I think a lot of women face that. I think
Yeah.
often when you're rotating, I love seeing on Instagram and stuff nowadays when people point out like you're often like not believed, or your intelligence is automatically doubted because of the
Yeah.
way you look. And again, I think that goes for a lot of different people, especially racism, I would imagine, is right up there, might even win out sometimes, where like they look to the male med student for advice, and you're like, they don't know anything, like what are you looking at them for?
Yeah.
But I think also for me, like I was in a committed relationship before med school. I'm married to that person now. We have children. I always knew I wanted to be a mom from very early.
Mhm.
And so for me, also going through it, I always knew that picking a specialty, that was also on my mind. And that was kind of like taboo, I think, to say. Or, like one thing that stuck out to me in my OBGYN rotation was I was like, I don't think I want to take 48-hour call for my whole
No.
life. Like
Yeah.
I personally desire to be a hands-on mom. And I knew that really early. And I feel really lucky that I
Yeah.
had that intuition and really stayed by it. But that also affected where I wanted to go. And that's just my journey. I know plenty
Yeah.
of women who are neurosurgeons, and they have their kids and they have a very full life. But I think like it's nice to make room for all types of careers in motherhood.
Yeah.
And I wish that, and I hope that people talk about that more, that it's okay to want those things and to keep it in mind. And it's
Yeah.
actually probably really important. I don't know what the studies are, but I'd imagine female physicians, I think, struggle with infertility, maybe at higher numbers than the average population, because we're
Oh yeah.
in training for so long and you sort of put it off.
Yeah. It's one of those kind of like silent epidemics of
Yeah.
female, or we'll just kind of be gender appropriate. But like people who are able to have babies, like they
Hmm.
struggle in the medical field, just again for the reasons we're mentioning, that we're pushing the age a little
Yeah.
bit. They're often, when they're done with training, they're closer to that quote unquote high risk pregnancy age versus being super fertile and early and all that
Yeah.
stuff. So
And then I think it gets tricky when you are pregnant
mhm.
in residency or in training, and then it can, affect the call schedule, and then your co-residents might get really mad at you. I had a really bad experience in my training in regard to that. So I think those are the sorts of things where you're just sort of like, huh.
Yeah.
Well, that kind of sucks.
Yeah. And I know even from, my own history in a way, or my family history is like my mom, she's an immigrant from Pakistan. She came over, got married to my dad, who was immigrant as well, but he was here beforehand. And she's a doctor, or so she did her medical school in Pakistan. And then she had me and my sister, and and then she went into residency into family medicine. And the thing that's always kind of like we heard from like her mentors and her people was like, she was going to be a fantastic OB-GYN and she wanted to do OB-GYN. And but she gave up that career in a way for us, me and my sister, to have us, just because of exactly what you're saying of, like, I don't want to be on call for 24, 48 hours and all that stuff. So,
and for some women, that's totally fine. Like, for some reason, I did my OB/GYN rotation like during Thanksgiving time. And like, these are the silly things that stuck out to me. But it's like, I'm glad they did, because I was like, but I really want to be home making the meal. Like, I don't want to be in the hospital. I don't want to buy it. I don't want to cater it. Like, I want that. And like, but I felt like I couldn't say that, because then am I like not a feminist, or am I not dedicated to my career? Like, you get a lot of opinions as a woman in medicine. Like, I've had so many mentors, even now, even like present day, say things like, well, you're not like a real doctor if you don't work on nights or weekends, or, it's a waste of your training, of society investing in you if you work part-time. There's like a lot of opinions out there about it. And I just feel like that's not very nice.
Yeah. And it's like, if you become a public servant, you have to be 100% a public servant, and your whole life is
right. And
gone.
it's like, I like the hands-on motherhood, not every second of the day, not when we have theme weeks. We've talked about that before. I wish those would go away. It's too much pressure. But I personally like that. I know not everyone does, and that's okay. Like, there's room for all of it, but I feel like it's unfortunate to feel like you have to keep that quiet. And that's one thing, like, as I've grown now into my career, and maybe you're talking to other people now in training and stuff, I try to be open about that, so they know that like you can carve out your own path. And I think, like, again, at the end of the day, we'd all love to save the world, but we can't do it all by ourselves. So if you can really find a setting where like you're really fulfilled in your work, great. And I think like I've had to wrap my head around like, so maybe I'm not going to treat like every single pregnant person in Connecticut. That's not realistic. But the ones in my care, I'm going to do a really good job at, and I'm going to feel more fulfilled in that work when I have a work-life balance. And like, that's okay. That's actually important.
It kind of matters. It's kind of a big deal.
Yeah, it turns out that also matters.
And it's, the care that you give also improves when you're satisfied in it as well.
100%, right?
Yeah.
I'm just thinking of Jesse with all the burnout and healthcare. Like, turns out, I love when there's like data to back up stuff that's like, we know, right? That's how I always feel about reproductive psychiatry. It's like, duh, these hormone fluctuations affect people.
Yeah. Duh. All right, let's come back to that and talk about that. So we all know, in theory, about postpartum depression, right? That's the most common one, right? I think,
100%.
Everybody knows about that, and everybody's
I hope so.
Hopefully, right?
Yes.
But we know that people don't, but we'll work on that. Can you give us a little info on what that is, and what's the baby blues, and what's not?
I'd love to.
Yeah.
I love talking about this stuff. So postpartum depression is the number one complication of pregnancy. I'll say that again, because most people don't realize that. Postpartum depression is the number one complication of pregnancy, beyond hypertension, gestational diabetes, preeclampsia. All those things are really important too, but this affects the most people. So the stats that we have presently suggest that it affects 1 in 5 women and 1 in 10 men. So again, I always mention that because we also like don't talk about the dads, and we should. And it also implies that it goes beyond just the hormonal fluctuations, but obviously that's a huge part of it, especially in women. So 20%. And as we know, the number's probably way higher because there's always cases we don't capture in doing this data collection. So postpartum depression is, after you have a baby, I always tell my patients, like, when you're giving birth, your hormones, your estrogen and progesterone in particular, are the highest they've ever been. Like, think of the tallest roller coaster in the world. In the second and third trimester, you are just chugging it up. You're chugging. You're going way to the top. And then right as you deliver your baby and they remove the placenta in particular, they crash. Those levels come down very quickly, very rapidly, the quickest of your whole life. And it makes you feel like you're losing your mind. Like I remember being all over the place. And I remember when I was, after I had my son, I was like, oh my God, they're going to call a psych consult on me and it's going to be someone I know. Right. Because I delivered at the hospital I was training at, because you're all over the place. But that's normal, right? Those first 2 weeks in particular is when you might have the baby blues, and up to 80% of women experience that. So it's far more likely you'll experience it than you won't experience it. So I try to just normalize that for people. Your moods are going to be all over the place. You might be like, things are going to make you cry that would have never made you cry. You might laugh inappropriately. You might have energy, then you might feel really tired. You are just all over the place. And that's normal. And then that's in addition to just like adjusting to having a newborn. That's hard too, right? And you're not sleeping, you might be trying to breastfeed. It's all like really tough. And then for most people, that will resolve slowly on its own, usually within the first month. But for a lot of women, it doesn't go away. And so that's when we start to think about the condition called postpartum depression, which looks like depression, but it happens in the postpartum period. That's really the only special thing about it. So I always tell people, I kind of see two variants of it in my clinical practice. One is more of the like typical kind of like Eeyore depression, like boohoo, crying, struggling to get out of bed, feeling really down on yourself, really critical, thinking you're a bad mom, having trouble connecting with your infant. And then the other version has all of that, but also has this like irritable edge, this anxious kind of revved up edge. And again, in non-postpartum depression, we see that too. But I always tell women that because I see a lot of women who have like rage or they're just like angry all the time. And oftentimes that's within postpartum depression. And then in the, most severe cases, you also start to have suicidal thoughts or feeling like, your family would be better off without you. And again, that's where we need good evaluation because it's also normal, spoiler alert, to have times when you've just had a baby to like want to run away. Because it's really hard. And that's just like, that happens. That's normal. That doesn't mean you have postpartum depression or you're a bad parent. It's just like a really hard transition. So that's how I think about postpartum depression. And again, we start to diagnose it around 1 month postpartum. Most commonly, people are diagnosed within the first 3 months postpartum. And interestingly, if you trace it back, 60% of cases actually started in pregnancy, but were either not identified, inadequately treated, or got worse enough where the woman's finally seeking help. And you can diagnose it all the way up to a year postpartum because it takes that long for your hormonal systems to re-regulate.
So we have this nice long window of like up to the year afterwards. Because I think I've had patients who have been like, well, it can't be postpartum because I had like a baby like 6 months ago, and I was like, no, we're
still in there.
We're still in the window. It's
still exactly. I know, and I think that's just like our society's like expectation that you just like get back to
normal.
You just like get back to normal, right?
We just have like COVID. Everybody like just get back to normal. We just have all this and this.
No big
just
deal.
Get back to normal.
Like,
just had a baby. Go back to normal.
Whatever. You just had C-section. Whatever. You don't need pelvic floor PT or like you don't need an abdominal binder. Like who needs that?
Yeah, just get back out there.
Just carry your 10-pound baby and like suck it up.
Do some deadlifts and you'll be all good, right?
So who cares if you like herniated disc? Whatever.
Yeah, no biggie. So what are some ways that like, again, well, let me say this. Aside from postpartum depression, let's pivot. What are some ways to treat postpartum depression? Most common ways. And then I know there are some developments. The new medicine just came out. So,
very exciting. Very exciting. So the first thing is we have to identify it. So back when I was in training, ACOG like passed a bill or whatever they call it. It's not called a bill, but like they made some announcement.
Guidelines,
like, all right,
whatever.
Guidelines.
Guidelines.
They were like, everyone, we need to screen for this. Right. And we're all like, hooray. So everyone gets the EPDS. Ideally during pregnancy, like each trimester would be great. Even a
EPDS is something depression scale, right?
Yep. The Edinburgh Postpartum Depression Scale. Thank you.
Yep.
You could also do a PHQ-9, which we use the patient health questionnaire, but EPDS has been especially, studied and validated in the perinatal time. It also has some questions targeting anxiety symptoms. So you can kind of screen for both with one questionnaire. we have to identify that people are struggling with these symptoms, but then we have to get them into treatment. And there's a huge gap there. So 75% of women who screen positive don't end up accessing care. And those numbers are way higher than outside of that time frame. So I think the numbers are like, I don't know, 20 to 40% maybe who screen positive at other times in their life don't access care. So still not great, you know, but like way higher at this time frame. And it's treatable. That's the great thing. You know, more mild cases can respond to therapy alone. Increased psychosocial supports is huge. And that's where I think, especially in our American individualistic kind of culture, we really are struggling. You know, there's not as much of a village around women anymore.
Yeah.
There's a lot more stressors that women are facing, doing it all alone. So, I mean, just shoring up those supports goes a long way. There's support groups these days, especially things like Postpartum International does a lot of wonderful work. They have a whole directory where you can find a provider in your area who focuses on this. There's a National Maternal Mental Health hotline that you can call. PSI has a hotline too that you can call, and both of them offer English and Spanish options. And it's totally free. They can connect you to providers. And then there's medications, which help and another big part of what we do in this time period.
And medications, I know, like, I think a lot of the OBs were just like, yeah, we'll throw 50 of Zoloft at you and good to go, right?
Yes. Yeah. Let's switch everyone to Zoloft, which please don't do that anymore. So again, like, name of the game in reproductive psychiatry. And again, I guess I should say, like, this isn't medical advice. So if you have any questions about yourself in particular, please consult your own provider. But again, like, what we know is if you've experienced a mental health condition prior to pregnancy, you're likely to experience an exacerbation during or after pregnancy. So we don't take everyone off their meds anymore. Or we shouldn't, I should say. People still do. And then these patients come to see me and I'm always like, you poor thing. Like, you would have been fine on your Lexapro, like, or they'll switch them from whatever they're on to Zoloft. Like, please don't do that. I think the reason people do it is because Zoloft, of all the SSRIs, has been the most studied. But all the SSRIs have been studied. They all work the same. Whatever's worked for you, stay on it. Zoloft has the lowest transmission in breast milk. So if they've never been on an SSRI, that's when we usually start with. But for medications, we usually start with SSRIs. And those can take a while to fully kick in. So that is when, you know, it's helpful to be engaged in therapy or in a support group or things like that. You have to focus on prioritizing sleep, which is really hard when you have a newborn. You have to focus on addressing any of the needs between the mom and the infant themselves, their connection. If the infant's having any issues, if they're in the NICU, if they're having reflux, all that's going to make it harder. You got to focus on dad. You got to focus on everyone, right? And we just don't do a good job of that so far.
I know I did talk with Dr. Devika Bhujan. She's a pediatrician with bipolar disorder, I think. And that was one of the things that really, one of my main takeaways from that was, like, you know, when she was having a baby and she had episodes of mania in the past, and, you know, the number one thing she was like, we're hiring a nanny for nighttime.
You have to sleep, especially if you have a history of bipolar disorder. You have to. And they've done studies where it turns out it's not the total number of hours of sleep or the lack thereof that affects women. It's the number of awakenings that neurologically you see that. They did like EEGs and stuff. And then that correlated with higher symptoms of anxiety and depression, especially with bipolar disorder. We know, you know, sleep is a huge trigger, and especially in that time period. So I try to tell my patients, anyone, but especially with bipolar disorder, if you can get a 6-hour stretch, you feel like a whole new person, right? After you've had a newborn. But that involves a lot of support. Your partner, you might sleep in a different room from the baby. That might be hard. You might sleep next to the baby, but maybe you put earplugs in so you can actually get into a deep sleep. Or you might have a nanny or a night nurse or your mom or someone else, a friend around to help you.
I know, like, we just had a year plus now ago, we had our last baby, hopefully our last one. And, you know, for this time, you know, I made sure that, like, I got like a month off for paternity leave, which was like fantastic. And I was like, I'll take night shift, you know, and that's
really
just
nice
kind
of you.
I was like, that's what we did. So it allowed me to catch up on a bunch of movies, but you know, that's, you know, it was night shift. And like, so wife did like a lot better than she had done in the past. I don't think she may have had some postpartum depression stuff for the other ones, but like this was like much smoother recovery period for her.
Yeah, you got to sleep, right? And for a lot of women, that's really hard though, especially when it's your first baby or if you're
Yeah.
feeling anxious. That's another telltale sign for me of someone who's struggling, is when you finally have a chance to sleep if you can't.
Yeah.
Like if you're up ruminating or you're feeling guilty about sleeping or you're having psychotic symptoms, like that's a telltale sign something's up and that we should treat you.
Yeah. And then the nutriment. So we
Yes.
touched upon this briefly. Talk about that. I know you've done some talks on that.
Yes. So this is a really exciting development in our field. So again, I also want to mention that other types of treatment, so SSRIs or other medications, that's like our go-to for medication, and they work well. They just take a while to kick in. Some women might need a sleep aid at the beginning or like a short course of a benzo to bring everything down a notch. And people are very scared to do that, especially if you're nursing. So we always talk about the safety. And again, we have to move away from comparing the risks of medication exposure against the risk of no medication exposure, because that's not actually what's happening. What's actually happening is we're comparing the risk of medication exposure to the risk of untreated mental illness, which is not good. That actually has a huge disease burden. And again, now we have more and more data to show that. But then there's also treatments like ECT can be really helpful. TMS, less so than ECT, but like those sorts of things can be helpful too. Yeah. And in the past few years, they have developed a whole new type of medication. Brexanolone was the first IV medication approved to treat postpartum depression. It did require like a several day inpatient hospitalization. There's some hospitals like at Brown, they have a mother baby unit where you can bring your baby with you, which is great. I think that'll definitely increase, women's ability to take advantage of that treatment. But again, because it's IV, because it involves an admission and it is very sedating, that
very
is usually very expensive. And again, I don't know, but I would imagine because insurance sucks that they would require you to fail things first and like all this stuff. Yeah. But that's usually reserved for like very severe cases. In November, I believe it was, the FDA approved the first oral version of that called zuranolone or Zurzuvae. I might not be saying that right. I love how we always have like the weirdest words for medicine.
Yeah. Zuzu, I call it Zuzu. Zuzu.
Zuranolone is what it's called. And like the cool thing about these medicines, so what we've learned, I just love the science behind this stuff. So what we've learned is it doesn't really matter like what your hormone levels are. So there's no need to check those. Any provider who's telling you like, let's check your hormone levels, they don't know what they're doing. You don't need to check that. It's the drop that is important and that affects some women more than others. Okay. And so that's the thing. And what happens is, especially, estrogen affects it, but also progesterone, it turns out, is like really important. And when progesterone gets metabolized, it gets broken down into a compound called allopregnanolone. And that's like so far what we've been targeting, because they've done all these studies and it turns out women with postpartum depression, anxiety, whatever it is, they have lower levels of allopregnanolone in their blood and their CSF compared to women without these conditions. So people were like, okay, so like how do we supplement that? How do we make like a synthetic version? And it's been really hard to do because it hasn't until now had great bioavailability, which means like you need to take a huge dose to get metabolized and then like get into your bloodstream. And that dose until now would be way too sedating. So that's why they had the IV version first. And now we have an oral version, which still is sedating. That's the biggest potential side effect. I haven't prescribed it quite yet, but for my colleagues who have, they've said that their patients are not, overly sedated. They can still get up in the night to care for their infant and things like that. So that's pretty exciting. But what's super exciting is that it works totally differently than SSRI. So it works on the GABA receptor, which, as we know, is a very important receptor, but also has potential for abuse, right? Like benzos and things like that. So it works on a different site than benzos, which I think is cool. It's still considered a controlled substance and it carries that potential risk, I think, because it's working on the receptor and we don't totally understand it yet. But basically, like when you open up GABA more and it's, the stuff is flowing better, people feel better. So that's sort of how it's working. And the cool thing is when they did the studies, they used the HAM-D, which is another depression screening form. Patients with postpartum depression showed symptomatic improvement by day 3. Yeah. 3. And they only needed to take it, I believe it was for 14 days.
Yeah, right. It's like a 14-day take home
That's it.
or mail order
Yeah,
kind of
it's
thing, right?
almost like an
Yeah.
antibiotic. You know,
Yeah.
like I'm like in our field of psychiatry, like we've never had that.
Yeah.
And when they did the same treatment for people with depression who were not in the postpartum period, they did not see that. So they did not see, improvement in HAM-D scores. They didn't see that. So there's something about this mechanism. And how cool is that? That's
It's
so cool.
it's like amazing. Because like I know like I've had a recent at my outpatient clinic, you know, I do see some adults. But like
Every now and then the grown-ups
every once in a
sneak in.
while they get in there. But like I had a postpartum case recently and they needed, they were an ECT one.
Right.
And yeah, and it's like people don't realize it's like
Oh, you could do this.
postpartum gets really bad. And it's
Yes.
like it's exclusively during that period, and it had happened before for the last
Right.
baby, and it was like ECT, and that's the
Right.
thing that we did. So this is
And
like
ECT
totally,
also works really well
it works
and can work
fantastic.
quickly. And
Yeah.
like, again, but people are scared of it,
People are scared.
So, I mean, to have something like this, again, I
Mhm.
just am like, I can't think of a time where in psychiatry at large, we've had something that's almost like taking an antibiotic. And again, there's still a lot we don't know.
Yeah.
We still have to see, like, does this persist? I think they studied it out to 45 days and the effect persisted. That's exciting. But we don't
Yeah.
know if you're going to need maintenance treatment like you sometimes do with ECT. The other cool thing is you don't have to adjust the other medications the woman's on, which is
Mhm.
great. So if you're already on your SSRI, you could add this on.
Because it works
So
a
again,
totally
you
different
just,
mechanism. Yeah.
yeah, exactly. So I'm just like so excited. Again, I'm hopeful that like it's not going to be one of those like things 20 years from now where we're like, "Rah, turns out
What
that
do we
was a big
do?
mistake."
Yeah.
But it's like really exciting, I think. And I wouldn't be surprised if in the future we might be able to use it at some of those other transition points in a woman's life.
Yeah. What else? So there's postpartum depression. We know that.
Mm-hmm.
And there's more than
Oh,
just
there's
that,
so
right?
much more. And I love to
Right?
talk about this.
Yeah. So what else? What else is there?
Everything.
Everything else. Yeah. It's
Everything you
everything.
can think about.
Yeah.
So, like you were saying, most of us hopefully are starting to talk about postpartum depression. Wonderful. But that's not the only thing that happens. I would say the other most common mental health conditions that show up in the postpartum period, in order of frequency, we're going to start with the next most frequent would be postpartum anxiety,
Mhm.
followed by postpartum OCD, and then postpartum psychosis. And then all around there, we also have to think about trauma.
Yeah.
Whether it's trauma directly related to pregnancy or childbirth, related to prior pregnancy losses, or just trauma in general can
Yeah.
certainly flare up around this time.
Yeah.
So I'm always trying to think about that in my mind. And again, it's important that sometimes what, we might think of as like an index trauma, to use jargon,
Mhm.
might not be like what the patient felt traumatized by. So that's really what matters. And I would also say that anyone who has had a difficult childhood themselves, for whatever the reason, a difficult relationship with their own parents, I think of the postpartum period and your transition to parenthood as being like a two-way mirror. Oftentimes, a lot of that psychological distress starts to come out as you start raising your own children. And
Yeah.
that's one reason I love doing therapy in this time, because it's such a ripe time to do
Mhm.
processing and reparenting work, like reparenting yourself as you're parenting your child. It's hard, and you have to, again, be like overall stable to do it, but it happens.
Yeah.
But yeah, postpartum anxiety, that can be anything from a generalized anxiety picture. A lot of women in the postpartum period experience intrusive thoughts or intrusive images. And often it is about harm coming to their baby, which is
Mhm.
really scary. If there's then compulsive behaviors or avoidant behaviors that go along with that, then we call that postpartum OCD.
Yeah.
And I see so many women who come to see me and they're very scared to tell me they're having these thoughts or images because they're afraid that I'm going to call DCF, I'm going to take their baby away. It means they're losing their mind, they're a bad mom. If those thoughts and images are distressing to you, you have anxiety or OCD. If they're not, that's when we start to worry about psychosis. And so I
Right.
wanted to make that point because postpartum anxiety happens, I'd say, I can't remember the numbers off the top of my head, maybe like 10 to 12% of patients.
Sure. Yeah.
OCD, maybe 4%. postpartum psychosis is 1 to 2 in 1,000 births. So
Mhm.
0.001 to 0.002%, way less,
Yeah.
but the most severe condition, maybe in all of psychiatry, honestly, because it's associated with a 5% risk of suicide and a 4% risk of infanticide, where the mom ends up killing her children, which is devastating. And those are very high rates compared to other mental health conditions.
Yeah.
So it's important to make that distinction.
Yeah. So talk about that like a little bit more, I guess. So you're saying like, yeah, the intrusive thoughts about like, harming the baby is not uncommon, right? And I
Very
always,
common.
yeah, and I definitely like tell new moms, I'm like, that is not something to be necessarily concerned about. But I
It's like
guess
really scary to
it's
experience,
scary. Yeah.
especially because they're often about the baby. So the one I
Hmm.
see all the time just in my practice is you're doing the dishes and you see a knife and you have this flash thought of, oh my God, what if I cut my baby?
Yeah.
And you're like not holding the knife. You have no
Yeah.
desire to do
Yeah.
this, but you're like, oh my God. And sometimes you get an image of yourself like slashing their cheek.
Yeah.
That's like just terrifying,
Disturbing.
right?
Yeah. Yeah.
Or like you might be rocking your baby to sleep and you think, what if I throw him out the window? Oh my God, right?
Yeah. Yeah.
It's also another really common one is what if I drop them when I'm going down the stairs? What
Mhm.
if an intruder comes in? Like all these really scary things. And you often get these like violent images that go along with it. And then some women might start avoiding going down the stairs. They might stay upstairs all day when their partner's at work, or they might scoot down the stairs on their bottom, or they might like distance themselves from the baby if they feel like they could harm them, or if their intrusive thoughts are about the partner, like not doing it
Mhm.
right or something, then they might not let the partner engage in it, And then if you add in any sort of like medical complication, like if they're having trouble gaining weight,
Right.
I'll often see people like obsessively measuring their baby. And some of those apps and stuff that we have these days, which can be helpful, can be like a tipping point for some people.
Yeah.
Um, so I'd say that is far more common. And then postpartum psychosis, what that means
Mhm.
is you may have thoughts like this, but they're usually part of a broader delusional picture. And it's usually an altruistic delusion. So by that, I mean, the mom feels like I'm just going to use an example,
Mhm.
receiving a special message from God that this baby has the devil inside them. And the
Yeah.
only way to cure them is to hurt them or kill them. That is the scariest thought to
Right.
have.
Right.
Again, what gets so tricky is when you have a patient who is having those thoughts and has enough insight to know you shouldn't tell anyone about that because they're going
Right.
to keep you from acting on it. And in your mind, you think you have to do this. So you also have to look for other behaviors of postpartum psychosis, hallucinations, other delusional lines of thinking, and again, these people might not come out and say like, I'm seeing things over there. You might just see them like looking in the corner kind of odd or muttering under their breath. They might be acting bizarrely. Their energy could be fluctuating pretty rapidly. They might be a bit delirious.
Yeah.
Like they might know what's going on in 1 minute and then later on not really know what's going on. They're often very euphoric and grandiose. They just are acting odd.
Yeah.
Any of that, please bring them right to the ER. And I always say, like, we also have to rule out anything medical going on because that could
Oh, yeah.
also be going on.
Yeah.
And in my experience, that's often been a way to get the patient to the ER because they're often really scared, especially if they're in that window of like they're having these symptoms but have enough insight to know this isn't normal, or they're
Right.
picking up that people are worried about them, but they feel great.
Yeah.
Often using that, we need to make sure that medically everything's okay is a way to get them there, which is really tricky. And then again, I declined to mention, but I should mention, postpartum psychosis
Mhm.
is diagnostic for bipolar disorder until proven otherwise. So you always
Okay.
assume, okay, this person has an underlying bipolar disorder we didn't know about. We have to treat them for that. So that's why there's also often symptoms of mania, like not sleeping, pacing, restlessness, grandiosity. They might be paranoid, things like that.
Yeah. Yeah. So, I mean, that was going to be part of my other next question in a way. Like, what are some of the potential, not say, warning signs or things to be watching out for, risk factors?
Yeah, that's a great question. So again, I think it's what gets so tricky, I think, for the average person is that the transition to parenthood, whether you're mom or dad, or you birthed the baby or you adopted the baby or what have you, it's so hard. I
Yeah.
always say, like, under the best of circumstances, it's
It's,
so hard,
it's still hard. Yeah.
right?
Yeah.
Just like, when you buy a house, that's great. It's so stressful, right?
Yeah.
And it can like bring up all this stuff. So this is like a very vulnerable time for anyone. I
Hmm.
think just, if you have people around you who know who you are or know like what your baseline is and noticing a change in that, it helps to just be like gently curious about it, you
Hmm.
know, like offer to help them out as much as you can in
Yeah.
terms of like meals or holding the baby so they can nap or shower, things like that. But, if you notice that their mood is different, if they're seeming more withdrawn, they're more tearful, they're more irritable, if they're talking negatively about themselves a lot, like these are telltale signs that they might be feeling depressed. If
Yeah.
you're noticing they're feeling really nervous, especially like they're always thinking something bad's going to happen to the baby, that's probably a sign they're feeling really anxious. And
Hmm.
then to just like normalize it for them as much as possible. Again, most women go through something like this,
Yeah.
and most women can get better with treatment, and that's okay. That doesn't mean you're a bad mom for seeking that out, and
Hmm.
maybe help with the childcare so they can get to an appointment, stuff like that. The more scary signs, I would say, of things like mania or psychosis, again, would be if the woman hasn't slept for 48 hours, especially if she's
Yep.
so revved up she can't sleep. Um, if she, again, is just displaying some bizarre behaviors or having these bizarre trains of thought you're having a hard time following, if she's talking really fast or not talking at all, or, talking and then suddenly stops, like these are signs of psychosis coming up.
Yeah.
And listen, I would say, to your gut. Like, I think whenever you're around someone, like your gut can kind of go off. So
Yep.
listen to that intuition.
Yeah. The spidey senses are a medical necessity, right?
Yeah, it's so true.
Yeah. And then, so we know that, we're talking about moms, right?
Hmm.
Or the new moms. And like, what about how does this impact all of this stuff, postpartum mental health stuff, mental illness? How does that impact bonding, attachment, all that stuff with the baby?
Yeah, for sure. Well, so I always, again, just try to normalize, like in
Hmm.
the movies, we always see that, you have a baby
Yeah.
and you like instantly bond with them. It's rainbows and butterflies. You've never loved anything more. And that's
Yeah.
it. Right. Like I remember that in like almost every single movie I've ever seen. I remember in Grey's Anatomy, there was an episode where Bailey had just had her baby. I don't know if you watched Grey's,
No,
um, and was
I've
in
avoided it.
surgery. She was in surgery and like the scrub nurse was like holding the phone up to her ear so she could hear the baby cry. And then she would tell the nanny, like, he's hungry, he's tired, blah, blah, blah. So you think like you should be able to know their cries. This is very unlikely. Okay.
Yeah.
Like if you have that euphoric connection right away, you're so lucky and like great for you.
Yeah.
That's
Oh, yeah.
wonderful. It's not common.
No.
I'd say it's far more common to be exhausted, in shock, maybe traumatized, maybe a little anemic, maybe like hungry, maybe like vomiting from the anesthesia. Like that's way more common than
Yeah.
just like instant euphoria and connection. And I always tell my patients, like, when was the last time you met a total stranger who spends all their time screaming at you and crying at you and you instantly feel love and connection?
Yeah. Never.
Never.
Yeah.
And if you did, we might think of it in a pathologically, you
Yeah.
might have like an attachment disorder or something. But so it's way more common for this to be you're getting to know each other process.
Hmm.
And I feel like unfortunately the babies don't really like perk up and start
No.
to be interactive until like the 3-month mark, right when you
Yeah.
go back to work, which is like so cruel if you're
Right.
lucky enough to have that long off.
Oh, yeah.
But so I always just try to normalize like attachment takes time to grow. And
Hmm.
it's okay that you're not going to know what they need right away. This is a learning process. That is not going to scar the baby.
Yeah.
Like that, you're both going to learn how to do this dance together and you're going to get there. And there's also help available. Like, I don't know if you're familiar with this type of therapy. I think it's called Circle of Security.
Yep. Circle security.
Oh,
Yep.
I love that. Like,
That's
there's
great.
all sorts
Yeah.
of different types of therapy and stuff available to help moms with that, especially if you're a mom who has your own attachment trauma.
Hmm.
This is hard and this
Oh, yeah.
stirs up a lot of that. And that's okay. Why wouldn't it? So I always just try to normalize that, but also say that having untreated or undertreated mental health conditions on top of that isn't going to help.
No.
Like it's not going to help the mom. It's going to be harder for her. It's not going to help the baby. It's going to be harder for them, but we can work on it. We can help you get there.
Yeah.
But it's when it goes untreated for a long time that it starts to really affect it. And
Yeah.
that's where even if mom is struggling, having an attentive partner or an attentive nanny or someone attending to the baby's needs in the meantime can be helpful. But yeah, certainly like attachment, we know, and working with kids is like
Yeah.
It's the
Huge. Yeah.
foundation of the house you build the rest of your life. And
Yeah.
so it is really important to address it, but also you're not going to totally screw up your baby if you're having a hard time.
Yeah.
We got some time.
Yeah. And I tell like the new moms and pregnant individuals too, is like all the time I was like, they're always concerned about like, oh my God, what am I going to do to damage the baby? And I'm just like,
Yeah.
I was like, the main thing is like happy mommy, happy baby.
Yeah.
And like your kiddo's going to do better if you're doing better. You're going to be
Right.
able to be more present. You're going to be able to do all the things like that you need to do, all the things that you quote unquote supposed to be doing.
Mm-hmm.
Like you can't do those if you're feeling depressed, anxious, psychotic, etc.
Right.
Like you need to be taken care of so that you can do those things then.
Right. And I think too, one thing I love about my private practice is I always say it's a baby friendly practice, like bring your
Yeah.
baby.
Yeah.
I used to have so many more babies before COVID and they're starting to come back. I love
Yeah.
seeing the babies, but I love seeing mom with her baby,
Yeah.
right? You get so much information and you can also do so much validation and encouragement of like, wow, look, you just really met your baby's needs. And it makes mom feel so much better. Just like emphasizing the good parts that she's doing and to remind her that some of that negative self-talk is probably whatever disease she's facing talking. That's probably the depression telling you you're a really awful mom. And
Yeah.
that's going to improve as we help you get treatment.
Yeah.
And this is when I love to talk about the concept of good enough parenting.
Oh yeah.
That your baby does not need a perfect parent. They just need a good enough parent. You're not going to get it right all the time. That's okay.
Yeah.
And they're going to be okay. And again, to take some of that pressure off.
Yeah. I'm sure you get the question all the time, right? From friends, right? People who are not necessarily patients who are like having babies and having all this stuff. And they're like, oh, you're a psychiatrist. Like, you know what to do. You're a child psychiatrist. Like, you know how to like, prevent these kids from being terrible. And, I tell them all the time, I was like, the number one thing you can do for your kiddos is just like, don't abuse them.
Yeah.
And, and again, the concept
Please.
of being, just be good enough, right? Like you just have to support them and just be there for them. And like most of the time, that's good enough.
I mean, that's huge to really, but when you think about like, what does that mean to really be there? It doesn't mean sign them up for all the activities and the perfection and all it just means like bear witness to them, listen, be present, be curious. But that is so hard to do when you're struggling yourself, and so that's where it's important to make sure you're taking care of yourself. And I think especially for moms, I'm probably biased as a mother myself, but I think you would agree.
Yeah.
Like you're so busy taking care of everyone else. Often your needs come last, but you got to learn, we got to shift that in our society somehow. And even like in the postpartum period, like, and these things sound like, this is where it sounds annoying. Like I'm saying like annoying self-care things, but really like tell your partner every day I'm going to shower. And it doesn't have to be for that long, but that 5 minutes, get your favorite body wash, get your favorite lotion, change your clothes, change the hospital granny panties, get outside as soon as you can in the morning to get the sunlight. These things go a long way and they're doable, but you also need support to do it.
Yeah.
But like if you have to put the baby down outside the shower and they're crying for 5 minutes while you bathe, that's okay.
Do it.
They will be okay. That is not neglect. Right. But I think for a lot of people, especially if you have your own personal history of neglect or abuse, it gets real tricky and triggering.
Yeah. I'm slowly reading through Dr. Pooja Lakshman's Real Self-Care book, and that's one of the main kind of tenets is like advocating for yourself and taking care of yourself and the structural changes needed for, more than just the yoga and stretching and bubble bath, right?
Right. More than like yoga and all this, which is, that's great. But you're not going to have time to do yoga when you just had a baby a week ago, right? But like those basic tenets of taking care of yourself, eating like enriching foods, but they got to be something you can eat with one hand. And you just have to accept like that's the phase you're in for now and that it won't always be like that. But those things are really important.
Yeah. One thing we talked about was ADHD, or we're thinking about was ADHD. Let's talk about ADHD in this period. So I know you're saying, go for it.
So, I mean, one of the, I tell patients now coming to see me for this, I say, and maybe I shouldn't, but I am always like, one of the joys of my life is diagnosing undiagnosed ADD in this time period. Because as we know, most women, most girls tend to have the inattentive variant. So they don't get picked up as much in school. unless they're really falling behind. So I tend to see women who are productive, maybe high achieving, they're working, they've figured out how to succeed because they had the natural cognitive capacity to do that, right? So then I always tell them, it's like, you can do that until you just can't anymore. And oftentimes that happens once you start, maybe you go to graduate school or medical school or law school, like the demands get higher. Maybe you have a demanding job or you start adding children, right? Just getting out the door in the morning is like the Olympics of executive function, right? Not to just get yourself out, but then you had kids with all their like stuff. If they're going to daycare, you have to like pack everything up with label. Like it's insane, let alone the freaking theme weeks like we've talked about. Like I am anti theme week. I think I'm gonna pass a bill. No more theme weeks. But like,
well,
honestly,
you don't like Disney theme week at all? No.
I mean, I love Disney, so maybe I'll get that one. But the one where it's like crazy sock day and then crazy hair day and then wear this color day. And I'm like, I never have that color. Pick red. Like, can we pick red? Anyway, but like, it's a lot. And so that is often when women are like, oh my God, I can't handle it anymore. And also the hormones like affect our brain and things get rewired. Like our memory gets rewired, like pregnancy brain is a real thing.
It's a real thing.
Right. Because like certain parts of your memory and hippocampus area and like all that stuff like kind of wither away. And then the parts that are involved in mirroring your baby, reading their affect, those grow. Like that makes sense. So we don't need to shame moms for like, having pregnancy brain, but all these things happen. And so it's been really fun to help women, help distinguish like, is it just sort of this postpartum adjustment, or is it under the context of depression or anxiety or something else? Or have you had ADD kind of your whole life and it just never got picked up? And that I find is a really interesting conversation to have and can come with a lot of grief for some people, a lot of relief for a lot of other people, often a mix of both, where once you start to treat it, oof, I'll never forget. I had a patient once tell me, it's like there's brains in my hands. And I use that now all the time where people are like, I can just do it. I don't have to think about it so much. And again, it's not like a perfect cure, but it certainly makes getting yourself organized, using timers, implementing those behavioral modifications way easier. And then often there is some grief about like, wow, my life might have been a lot easier if this had been picked up, and again, we often see, like, I'll often see these people coming in for anxiety and depression stemming from untreated ADD. So it's just another time where it's really fascinating and fun to work with these patients. There's not as much evidence for the safety of stimulants in pregnancy and with nursing. Most of the evidence comes from studies evaluating women who were using these medications illicitly, so at way higher doses than we would give it clinically. Again, the name of the game in reproductive psychiatry is treat the illness. Unless we know there's something that has this like clinic, like Depakote, for example, we know can lead to neural tube defects. Even still, if that's the only medicine that works for mom, we use it and we like supplement with folates a lot. We do more scans. Like you have to treat mom. So with stimulants too, it's always like a risk benefit analysis. Like if the mom's going to lose her job, because she can't, like you need treatment, and it's generally safe to take while nursing, especially if your baby's full term, healthy. If there's any, like if they were preemie, if they had neurological issues, breathing issues, we might think a little more. But in general, like it's okay to treat. And we also see this come up again in perimenopause time shift. So another time.
Yeah, I think it's, I love that whole aspect of like, I mean, it's one of like the great joys of this field of what I enjoy of like finding those undiagnosed ADHDs and that light
Isn't
bulb
it like
kind of
life changing?
Yeah.
It's life changing.
Someone who is like that person who was like a late diagnosed ADHD as well. And I was like, oh, I somehow made it through this part. But I was like, part of my journey to getting here was like failing out of dental school. Right. And
I
like,
didn't know that.
Yeah. So that was like, my few $100,000 that I'm still paying off is like, that's my expensive lesson that I was like, this is what my untreated ADHD is. Like, and, maybe my life would have been different. I'd be drilling and filling in upstate New York, but like
drilling and filling. Hey, there's still time.
There's still time. I can always go back and get another degree. Sure.
What's one more?
Just throw it on there. Yeah. No biggie.
Drilling and filling. I like that.
But yeah, no, I mean, that's what happens right there. And I see this so many times, like the grief that you mentioned, right? So many people are like, oh my God, what my life could have been. I wasted my life. I should have been doing this. I could have been doing this. And that's hard
And
to
it's
kind of
okay.
manage. Yeah.
Yeah, it's important to make space for that and to process
Hmm.
it like any other grief. And then I'll also see, I think just in my line of work, people scared like, oh my God, I'm going to pass this on
Yeah.
to my baby, depression, anxiety, OCD, ADHD. And I always say, like, you're going to pass on a lot of good traits too.
Yeah.
And oh my gosh, if this child gets that, which it's not a slam dunk, they will.
Sure.
Oh my gosh, how nice that they have a parent who's walked the walk. And it's
Yeah.
like, it's going to like make me choke up even now because I really believe that. Like, you've walked the walk, you're getting your treatment, you're going to pick it up so much earlier for them.
Yeah.
You're going to know
And
how to
knows what
support
to
them.
watch for. Yeah. Knows what to look
Oh,
for. Yeah.
what a gift.
Yeah.
Right?
Yeah. Oh, yeah. I think it's huge because so many times we see, like, again, when I'm working with my teens, like parents being like, I had no idea. I had no idea. They looked
Yeah.
fine. Everything was all good. It's like one of the most common things we see, unfortunately, like after overdoses,
Oh,
is like, when parents are like, I had no idea.
oh
I
my
wish I
gosh.
had
Yeah,
known. And it's almost always happens.
I
So,
know.
excuse me. Okay. Let's talk about, as we're wrapping up a little bit.
I know I could talk forever. I just
I
get
know.
like so excited about this stuff, and the biology is so fun. And like,
I was like, we may have to do it. We may have to do like another part.
I would love to. Like,
yeah.
I just want to talk about this stuff far and wide as much as I can because like women just don't know this stuff. I don't understand
Yeah.
why they don't teach us this stuff. Even in residency, we don't learn this stuff.
Well,
What?
we know why. Just because like men control medicine and men are men are terrible, and we don't care about women, right? They should be
I
like
know.
Harrison Butker said, like in the kitchens and having children.
Oh my
Fuck,
God.
fuck Harrison Butker.
Oh my
Fuck that guy.
God. I posted something,
Yeah.
but like Portia had posted a picture of us, and then I reposted it, and he saw it because you know how you could see on Instagram who looks at it, and I was like,
Yeah.
"That's right, Harrison. You saw I tagged you."
Yeah, go fuck yourself, Harrison Butker. I hate that guy. Anyways,
I didn't realize the crowd was like cheering. I thought they were booing. That was it took me a minute.
Yeah. I can't, it's like, we're living in this like weird world where like this stuff happens and people are like, oh, yeah, cool, he's great. And now he's the number one selling jersey in the NFL for some reason. Yeah, something like that. And I was just like, why? So we can burn them, hopefully? But
gosh.
I don't know. Who knows? Anyways, off topic a little bit. What, I know you had talked about so your journey for your education, for that aspect of it was like hard because you had to find people. So what are you doing to kind of like maybe fix that for the next generation?
Yeah. Well, so I love my private practice where, we really focus on women's mental health. I'm hoping to grow that in the next year and start hiring some colleagues to sort of grow. I love being involved with our state's hotline. And then I am launching a new platform, hopefully in September of this year, called Repro Psych Academy, where there's going to be 2 arms, one for providers and one for all women come from wherever, just normal people.
Yeah.
My goal is, again, there's not enough psychiatrists, period. There's not enough reproductive psychiatrists under that. I don't really see like Congress and people like, making more residency slots and stuff. I don't understand why. So, okay. So I'm just like, how do we get this knowledge to the people? And so I'm going to launch Repro Psych Academy with the goal of having these 2 arms, one for providers to really just like teach this knowledge. And there's going to be 3 pathways within that, a foundations pathway, which is the basic pathway, proficiency pathway for people who want a little more, and then the advanced psychopharm pathway for people maybe like, who are practicing psychiatrists and want to learn more about like, how do you dose lithium in pregnancy and postpartum? Because you just have to be careful about some things. And like, we don't learn this and like, let's learn it.
Yeah.
And then I'm hoping to also have an arm for just normal people who want to learn about like what happens in your menstrual cycle, like what's FSH, what's LA, like why don't we learn this? I don't understand, but like let's learn it. So I'm hoping to start launching that this year, and I'm really excited about it.
Awesome. Well, that is, I think, is going to be a huge valuable resource because, like, again, the system is set up to not be supportive and not be helpful for this. And it's kind of like, oh, we'll just leave it, just refer to OB-GYN and they'll take care of everything. And it's like,
and OB-GYNs, like, they know a little bit, but even they would love to learn more. They would love to learn beyond just Zoloft. Like, what else can we do? Or even for women, like, why don't, like, when we have like period class in middle school, why don't we learn like, this is how it affects your mental health. This is how birth control affects your mental health. Like, guess what? This is going to happen in menopause. Like, why don't we talk about this stuff? I don't know.
Yeah. Because of men. So
you said it, not me.
Hey, I always, kind of references like my mom is a physician and she was the one who was a major impact on my life and
Oh,
very strong role model for me, and I had wonderful female role models growing up. So I've
that's great.
always been a supporter and a lover and all that fun stuff. And
I love to hear that. One of
yeah,
my
and
favorite attendings in residency also said the same thing.
yeah,
He was like a really good therapist, and someone was asking him like, "How'd you get to be so good at this?" He was like, I just had like a really good mom, and I was like, oh,
yeah. I had like wonderful cousins and like younger sister who were great. So like they really, and then, going into this field, like we know psychiatry, especially child adolescent psych there's a female predominance now.
Mm-hmm.
And so that's, again, great mentors and stuff. So it's like,
Yeah,
why be a misogynistic asshole?
like why?
Yeah.
I don't know.
Makes no
Doesn't help.
sense. Yeah. So, all right, Dr. Fury, any last plugs or things or comments, questions, anything? Or, oh, wait, I have to ask one thing. Yeah. What is your favorite self-care?
Oh my gosh, my favorite self-care. Okay.
Mm-hmm.
I
Besides
am
movies.
I am a Bravoholic, okay, especially the Real Housewives.
Yeah.
And I realized I've been watching them as long as I've been as like Real Housewives of OC premiered the year I started either college or med school.
Mhm.
So basically, I feel like I've also learned a lot about personality dynamics and personality disorders and stuff from Bravo. I love Bravo. I love the Real
Yeah.
Housewives. One of the like highlights of my life, Sulman, was I was on a podcast earlier this year talking about the Real Housewives of Salt Lake City finale, and it was like the best hour of my whole life. It was so much fun. So I love that. And I also love to run.
Yeah.
I was a runner, back in college and med school, and I've been able to slowly get back into it after having my kids.
Mhm.
And I'm finally back to like running regularly, and it feels
Nice.
so good. So if I can run while listening to my favorite Real Housewives podcast, which I'm going to do right after this,
Double win.
oh my God, it's the best. That's my favorite
Yeah.
thing.
Awesome. Perfect. And do you have a favorite pair of sneakers, by the way?
So probably my Brooks running shoes, I would
Nice.
say. I don't wear a ton of, I'm not like what do they call it? A sneakerhead? Is that what you
Yeah.
guys call yourselves?
Sneakerheads.
I think probably because I'm a girl. So I wear more like flats and wedges and, boots and stuff. But I love my Brooks running shoes. And I feel like I really need to find a cute pair of like mom sneakers that aren't like athletic-y. So I just got like classic Adidas, which I kind of
Nice.
like.
Yeah.
I'm looking at some like classic Nikes.
Yeah. Can't go wrong with like some Air Force Ones or some like Air Maxes, some classic ones. So
yeah, so I'm trying to figure it out.
yeah. Cool. All right. Plugs and stuff. Any plugs?
Yeah.
What you got?
Well, thank you so much for having me on. I hope this is helpful to everyone listening. I just love talking about this stuff, and hopefully in a way that normal people can understand.
Yeah.
When I say normal, I just mean like in medicine, there's so much jargon. It's like a different language that I feel like we just need to like, let's like talk human.
Yeah, myself included. Because
me too. Sometimes I slip into things.
I was like, what does this person say?
What's this word? But
what's a hormone?
Yeah, I know it's hard. When I worked at Yale with the undergrad and college students or graduate students, do you know how many times I would be in a session with them just nodding, and then I'd have to go Google some of the words they'd said instead because I have no idea these big words.
Yeah.
Like
fancy words.
Big fancy words. But so anyway, you can find me on Instagram at Dr. Katrina Furey, DrKatrina Furey. My private practice website is sound-psychiatry.com. And then that is where you can go to sign up for my newsletter, to read about what's going on, and to be directed to the page for the Repro Psych Academy. You can also access that by going to academy.sound-psychiatry.com. And then my podcast, which Sulman has graciously been on several times, is Analyze Scripts. You can find us on Apple, Spotify, everywhere. And you can find us on Instagram, TikTok, and YouTube at Analyze Scripts Podcast. And we are running a fundraiser right now through June 8th. I don't know if this will have already aired, but we're trying to raise money for the Catherine Violet Hubbard Foundation, started by Jenny Hubbard in honor of her daughter, Catherine Violet, who sadly died in the Sandy Hook tragedy. Every year, so she started this animal sanctuary in honor of her daughter. We just released a podcast episode today where we talked with her. She's one of like the most inspiring people you'll ever meet.
Nice.
And so every year on what would have been Catherine's birthday. They have a big event at their place where they try to adopt out as many animals as possible. They do a lot of great educational work. They're
Awesome.
doing work with seniors and helping them keep their pets. Like, it's just like an amazing testament to being able to find like the light in darkness after something so earth-shattering. So if you're so inclined, please check that out. And I'm sure they accept donations all year round. I think they're a wonderful organization.
Well, that's great. And it's one of those things where, like, we use our platform for all
that,
the goods.
Like to meet cool people like you and Dr. Jesse and like all these other people, but then like to do stuff like that feels really good, you know?
So, well, Katrina, thank you so much. I think we may have to do a part 2 at some point in time.
I would love to.
Yeah. So I know I've been on yours a few times, so we may have to have you on mine for a few times.
That'd be great. I'd love to.
All right. Well, thank you so much.
Thank you.